We're at the 20th CROI in Atlanta, Georgia, with three women who are very, very steeped in the knowledge of the pediatric AIDS and where we are today, and a particular case that drew a lot of attention to mainstream media this week. But we want to first cover, well, let's introduce you first. This is Lynne Mofenson, Hannah Gay, and Katherine Luzuriaga. And we'll ask you first to introduce yourselves and tell us how you're affiliated with your organizations.
Okay.
Lynne?
So I'm Lynne Mofenson. I'm the chief of the Maternal and Pediatric Infectious Disease Branch at the Eunice Kennedy Shriver National Institute of Child Health and Human Development at NIH in Bethesda, Maryland.
And I'm Hannah Gay. I am Associate Professor of Pediatrics at the University of Mississippi Medical Center and Director of the Pediatric HIV program there.
I'm Katherine Luzuriaga, and I am Professor of Pediatrics and Molecular Medicine at University of Massachusetts Medical School in Worcester, Massachusetts.
Now, Lynne, you gave an opening presentation that kind of described where we were and where we're moving, and I think that would be appropriate to kind of begin the program.
Sure. So pediatric HIV was first described in 1982, about 18 months after it was first described in adults. And at that time, 1 in every 4 infected mothers gave birth to an infected child. And there was really no intervention to prevent mother-to-child transmission. And in 1987, when AZT became approved for treatment of adults, pediatricians and obstetricians looked at that as an opportunity to potentially use AZT to prevent mother-to-child transmission. And so we designed a protocol where we gave AZT to the pregnant woman during pregnancy, during labor, and to the baby for 6 weeks. And that was called ACTG-076, and showed a dramatic reduction in transmission from 26% to 8%, and was really the first treatment as prevention demonstration. Since then, in the US, we've moved to universal HIV testing for all pregnant women, provision of anti-retroviral drugs, combination regimens now to the pregnant woman, and AZT to the babies, and elective cesarean delivery if her viral load is still high. And transmission in the US is now currently maybe 1 to 2% from the 25% that it used to be, and we've moved from about 2,000 infected babies a year to under 200. So in the US, we've had a dramatic success story. But in the global arena, it's been much more difficult. We have, following 076, done a number of studies that have identified shorter, cheaper regimens that are able to be used internationally to reduce mother-to-child transmission, and more recently identified regimens that are capable of reducing breast milk transmission. And with our current interventions, if we were able to implement them, we could probably get transmission in developing countries from 40% down to 5% or less. We've had difficulty in getting things implemented, and there are a lot of changes in the healthcare systems that are needed. This is very encouraging. Yet, we still have 330,000 infected babies being born every year. So the issues of pediatric treatment and getting treatment to children, and the issues of can we possibly intervene and get a cure, those are all really relevant issues. And that kind of brings us to other things to talk about.
There was so many CROIs where we had lots of back and forth about the importance of dealing with the reality of the pediatrics in the developing world with the formula versus the breastfeeding. And, well, this is the better way to do it because we don't have the formulas and so forth. And that's kind of moving in the right direction, I guess, towards formula. Is that?
No, absolutely not. Actually, initially that was the recommendation. People thought, well,
that
the way...
was a number of CROIs ago.
Right, in Africa, that we should just tell people not to breastfeed or to stop breastfeeding early. And what we found actually was that the babies were uninfected, but that they died of gastroenteritis and malnutrition. There are a lot of infectious diseases that breast milk protects against. So in developing countries where malnutrition is common and infectious diseases are common, breastfeeding is actually recommended. And what we needed to do was to be able to develop a way to have safe breastfeeding, as opposed to no breastfeeding.
So having them with the drugs, with the antivirals on board,
Right.
is the critical piece, along with the natural process of breastfeeding.
Yes.
That's right. I think
Yes.
there's a greater emphasis now in beginning. So when we first started to use antivirals to prevent mother-to-child transmission, we really focused on what we call the peripartum period, which is around the time of birth. But I think we are coming to appreciate the importance of treating mothers to keep them healthy. And so I think there's been a very encouraging move to treating mothers for their own health. That optimizes their own health, prevents transmission from them to their partners. It also then will allow them to breastfeed and whatever, and to hopefully reduce mother-to-child transmission.
Just a comment, though. In the United States, I
Yeah.
think the situation's a little bit different.
Yes.
Here we have safe infant formula that's affordable. Infectious diseases are a rare cause of mortality in infants, and malnutrition is not common. And here, because the only way to really truly prevent breast milk transmission is to not breastfeed, and given that in the U.S. these issues that we talked about in Africa are less important, and we have safe formula in the U.S., we recommend that women not breastfeed. HIV-infected women should not breastfeed, that they should formula feed. So it's really very situation dependent.
So basically we have to look at what the country's procedures are, because it'll be very by country to country as to how they propose to do it. What about women who do want to breastfeed? Is that something that's really, they seriously recommend against that in our country?
In the U.S.
Yeah.
So the American Academy of Pediatrics Committee on Pediatric AIDS just put out a bulletin regarding breastfeeding and HIV, and currently we don't recommend that HIV-infected women, even if they're receiving treatment, breastfeed. And that's because even with our most optimal interventions of giving the mothers 3 drugs while she's breastfeeding, there's still a residual risk that's as high as 3 to 6% out at 12 months. So that seems to me, if I was an HIV-infected mother, that's a risk that I would not want to take. And I have a choice because there's free formula available that will nourish my baby. So we don't recommend that women breastfeed in the U.S.
Can you give me a percentage of the difference between the risk benefit versus breastfeeding, or versus formula versus the breastfeeding in this country?
In this country.
Is there any way to
So in developing countries, breastfeeding is very important, particularly in the first year of life, in terms of reducing mortality in the babies, reducing them dying from infections or malnutrition. This same thing is not true in the U.S. because we've got safe infant formula.
I was just saying the difference between if they chose to breastfeed, would they be tripling their risk?
Well, if you if you're
In this country.
so if you are on anti-retrovirals during pregnancy and you're fully suppressed, your risk of transmission at delivery is less than 1%. So the chance of infection is less than 1%. If you're on those triple drugs and you breastfeed for 12 months, you have another chance of transmitting to the baby that could be as high as 6%.
Oh,
so
much
while
higher.
it's 6 of 100, it seems small. It's a risk that
It's much larger than formula.
well, yes,
Way-
yes.
way
Well, if the
larger.
mother formula feeds, her risk is nothing.
Yeah,
It's less than
exactly.
1%.
Yeah.
So that's why we recommend
Yeah.
in the U.S. what we do.
So we did have this press conference at the opening, and there was a lot of interest in the baby that became undetectable. How did that evolve? Can you give us the backstory on that and tell us the best you can understand, and in a way that it doesn't dramatize it? It seems like it's pretty straightforward, but there's a lot of questions still.
There are a lot of questions still, and we need to do a lot of research to find out answers to those questions. But what happened, in Mississippi, we worked very hard at preventing HIV by identifying moms during the pregnancy and treating the moms during the pregnancy. But we had a case about 2.5 years ago where the mom did not get prenatal care and did not know that she was HIV infected. So we missed that prevention part of treating the mom. She was tested when she came in labor, but did not get any medicine during the labor and delivery process either, because she had a rather precipitous delivery. So the only portion of our prevention strategy that we had the opportunity to use was the portion of treating the neonate with drugs as post-exposure prophylaxis. Unfortunately, the baby was born at a hospital where they couldn't start the post-exposure prophylaxis right away like we'd like to do. So that was yet another risk factor for this baby. So she had the increased risk of not having had the prenatal treatment. And in addition to that, she was slightly preterm, which is another increased risk by a little bit. And she was also late on starting the post-exposure prophylaxis.
And what was the timeline on that? Do you know?
She arrived at my hospital where she could get the medicines at about 30 hours of age. So I chose at that point to use more aggressive post-exposure prophylaxis than we would use for a baby who was born to a treated mom. So if the risk of transmission is very, very low because the mom was treated, we use one drug as, we use AZT as post-exposure prophylaxis. In this case, we had several factors that made it higher risk than normal. So we started 3 drugs at 30 hours of age. Just before starting the medicines, we drew blood from the baby that within the next few days told us that the baby was already infected. Now, by our definitions, a baby who has positive virologic testing within the first 48 hours is called in-utero infection. So the infection had occurred probably before the delivery. And at that point, I was looking at just an infected baby who needed multi-drug treatment, just like every other infected baby. So we continued her therapy, and she did well on that therapy. Her viral load came down over the first 29 days of life and reached below the level of detection at that point. It stayed that way. She was taking her medicine. She was coming to her clinic visits. Everything was as expected until about 15 to 18 months of life. She started missing some of her appointments. And after her 18-month visit, she missed several appointments. After 5 months, she came back in, and her mom told me at that 23-month visit that she had actually given the child no medicine since 18 months. So I fully expected that the child would have a very high viral load at that point. And I drew a viral load. I drew a genotyping to make sure that the virus had not become resistant to some of the medicines that she had taken before. And while we were waiting for the results of the genotyping, we got the viral load back, and to my surprise, it was still undetectable. I suspected lab error. I thought perhaps the samples had been switched. So I called the baby back in, and we drew another viral load and also drew a DNA PCR, which is another virologic test, and an antibody test on the baby all in the same day. And all of those came back negative. So I figured I was in over my head, and I called my friend Katherine and said, so what am I looking at, and what do I do next?
So what is this aberration, or is this something that, is there any way to explain it other than it is what it is? Or?
So when Hannah called me, I was surprised, but I was also intrigued. And I know Hannah to be a fantastic clinician, and you can explain, if she had called me with one negative test, I would have said, yeah, probably lab error, let's get another, which is exactly what she did. So now we had two sets of routine clinical testing that were unable to detect traces of the virus or the immune response to the virus. That's unusual. That's highly unusual in a baby like this. So fortunately, because of NIH and private foundation funding, such as AMFAR, we have been looking at the issue of early treatment of babies as a way to achieve long-term control and then eventually, to look at curative strategies. So we had a group of laboratory investigators that have developed very highly sensitive tests to detect the virus. And so we basically called, kind of assembled people and called them up and said, we have a really unusual case here. Can you help us understand this? And so, long story short, while we didn't detect any virus on the routine clinical testing, and we have not detected any virus on subsequent routine testing, using the very highly sensitive tests, we have been, on occasion, able to detect viral DNA or RNA from the baby's blood. Now, I have to explain that these are very highly sensitive tests. When we detect the viral DNA or RNA, it's really right above the level of limits of detection of the assay.
What was the assay down to?
So the RNA is down to 2 copies in the plasma, and the DNA is down to a few copies. So we're really talking right at the upper limits there.
Can be noise.
So the question is this noise or is this a true positive? And because the amounts have been so low, and because we can't take huge amounts of blood from a baby, we have continued to do testing, but we have not been able to definitively say that this was contamination or noise as compared to real. One thing, though, is that we do have a very sensitive assay that tries to grow the virus out. So it's one thing to detect virus in the circulation or in tissues. It's another thing to say, okay, if these viral reservoirs are present, how is there virus that can replicate and reignite viral replication off treatment? That's a concern for us because this baby has remained off treatment, and we as physicians would want to feel that, if this baby needed treatment, we'd need treatment. So we have done this very sensitive assay, have not been able to recover culturable virus from the baby. So we find that encouraging, but because we detect these low-level signals, we cannot say that the child has been cured.
Because you look at whether it's, you're wondering, is this seeded throughout the body, or is it just is it just noise? And I guess you're going to continue to look.
Yeah, I think there are two things that we need to do. One is follow the baby over time. And the second thing is to do some additional testing that can allow us to distinguish between those possibilities.
And so that is where you're at this point.
Yep.
And how are we going to follow up with this now? Will this be something you'll be willing to?
So this is an N of 1.
Yeah.
And while it's very intriguing and interesting, I think we have to. What we're looking for is something that will work for many children. And so what we are doing is, number one, redoubling our efforts to understand what happens when children are treated early, and there are a number of cohorts we can do that in. The second thing, though, which is happening through the NIH Clinical Trials Group, is to design a set of studies going forward that ask the question, So one of the things we thought was that by treating early, that we were able to severely curtail the size of the viral, what we call reservoirs, the hideout, the hideout places. And so these studies are being designed to address that particular question.
How are you going to be able to find?
if
We
Lynne
don't
wants
want to
to-
have untreated people before they deliver. So how do you
Yeah.
find the
So again,
subject?
I think this comes back to Lynne's point about absolutely being sure, and Hannah's point, being sure that prevention is the first strategy, that we...
It'd be unethical to do it any other
Oh,
way.
no. Unfortunately, we do find that because of social reasons or other things that women do not always participate routinely in prenatal care. And so I think we have to have something for those women. And
So you would say when they come to the hospital, have you participated in prenatal care? If you haven't, we have an approach that we're going to use immediately.
And in fact, a recent clinical trial has given us some new data.
Right,
Lynne,
right.
yeah, 040, yeah.
So two things I wanted to say. The first was that my institute has just put out a request for proposals to address this very fact. So we have some special set-aside funding to evaluate this case and other cases like it in more detail. And then secondly, in the U.S., we already recommend that if a woman comes in and she has not received antepartum drugs during pregnancy, that if you can, you start intravenous AZT on that mother right away, and based on the study that Katherine's talking about, you start a 2-drug regimen. In the study that we did, we looked at AZT by itself, AZT plus a drug called nevirapine, or a 3-drug regimen of AZT, 3-TC, and nelfinavir to see whether they would decrease transmission during labor more than AZT alone. And we saw a 50% reduction in transmission when you use 2 or 3 drugs. We didn't see a difference between 2 or 3 drugs, and actually the 3 drugs was more toxic than the 2 drugs. So currently in the U.S., the recommendation would be, in this situation, to use 2 drugs. Now, Hannah used a more aggressive regimen, and I can completely understand why, given all of these other circumstances with the mother. But also, even using our most optimal regimen, occasionally an infant will become infected. And the issue is being able to pick up that infection early enough and start the baby immediately on very suppressive therapy, like the therapy that was
Before
used
it
here.
seeds throughout the body.
Right.
That's right.
That's right. And now how feasible is that to do is another question. You would really have to be picking up tests within birth or within 48 hours and starting therapy immediately.
And have access to all that knowledge and that detail about, you're obviously were bright and did the right thing, and how many areas are going to be maybe in a backward situation.
Well,
that
this
won't be
wasn't
addressed.
happenstance. I think that it's probably fair to say that Hannah's expertise and many of our expertise were developed because we have had the opportunity and the infrastructure through NIH grant support to develop, to treat, to set up centers that really focus on treating HIV in our states and whatever. And while we may sit in academic medical centers, there's a very wide and broad reach out into communities. So I think that there is a network, a ready kind of made network that's available into which these particular types of activities are, where they're already ongoing. So I think this would, we'll do our best, but it's...
But you're talking about a very critical timeline.
That's right.
That's the thing
Well, I
we have
think
to...
the other piece here is that there's been experiments like this before. Katherine and I worked together on a study where we started infants who were infected on therapy as early as 3 months. But if you stop, those babies rebounded right back up. Their viral load came right back up. So one important message for the community is that just because your child is on therapy and their virus is undetectable does not mean that you should stop the drugs at this point. We do not have enough data to say that, and it would be very critically important and actually life-saving to keep the child on the regimen that they're on.
Thank you for bringing that to our attention. And we'll try to maybe find a way to repeat that because it's a very strong and important message. Yeah.
Exactly, and may I also say that Benjamin Franklin was right when he said that an ounce of prevention is better than a pound of cure. So if women are tested during pregnancy and in high-risk areas like Mississippi, they need to be tested during the first trimester and again during the third trimester. If they're tested during pregnancy, we can not only start treatment during the pregnancy, which reduces the risk dramatically, but on top of that, we can have things in place if she plans to deliver not at my hospital but at another hospital. We can make sure that hospital is prepared with the drugs that they will need for the baby. So, getting the care ahead of time is something that can overcome that barrier.
Lesson to be learned here. Yeah, I really thank you for that that message. It's strong. And Lynne, how do we move forward? Is there anything else that we need to be doing or promoting or encouraging people? I know this is a strong message, but there are others that might be worthy of mentioning here because we are moving forward. We're moving ahead with things like the cure. Hopefully there'll be one down the line at some point. So is there anything else?
I think from, in my talk, what I ended up with was whether we can globally eliminate pediatric HIV. And that doing that is going to require more than just making sure that women take drugs. We need to make sure that women have antenatal care, because if they're not seen during pregnancy, they don't get tested. We need to make sure that they're tested. We need to make sure that women in developing countries have the ability to make a choice about getting pregnant and be able to use contraceptive drugs. And we need to be able to be sure that they get the anti-retroviral drugs that they need. So there's a whole series of things within the healthcare systems that we need to work on in developing countries. And by doing that, we not only help prevent HIV, we will help to increase maternal survival and child survival in general.
Yeah. Well, I thank you all. Apparently Katherine had a little bit of a coughing spell there, so she had to leave early. But we really appreciate all of you for doing the work that you're doing and for bringing this to our attention. And we'll hopefully follow it and see where it goes. And the work that we're going to be doing in this is important.
Okay.
Thank you so much.
Thank you.
Thank you.